I practiced ophthalmology in the second half of the 20th century, starting in the 1950s and finishing pretty well in the late 90s, stretching 35 to 40 years, during which times there were enormous changes in the practice of ophthalmology. I grew up in Melbourne. I was a Preston boy from the northern suburbs, a scholarship boy. I went through university as a totally supported by a senior government scholarship and became a resident at the Royal Melbourne Hospital, where I came under the influence of then a doyen of Australian ophthalmology, Sir Thomas Travers, and I admired his benign cynicism about the vagaries of life and decided to take up ophthalmology. When I took up ophthalmology as a registrar in the 50s, what did an ophthalmologist of that period look like? Well, they were all pretty elderly because there'd been no training during World War II. And an ophthalmologist then could be easily recognised because he didn't wear an ophthalmoscope around his neck. He had this black cord from which was suspended a +10 loop. In his hand he held a direct ophthalmoscope, battery operated, two torch batteries. The head of the ophthalmoscope came off, which gave him a light source, and he could use that and his 10 degrees loop to do an anterior segment examination of the eye, which saved him the trouble often of using the old slit lamp, which is in a separate room. We have a whole clinic of ophthalmologists, but only one slit lamp, so that you'd have to line up for the use of one, so it was easier to use the loop. There was no indirect ophthalmoscope. Cortisone was just coming into use. Penicillin was just coming into use. There were no tetracyclines. Eye injuries and eye surgery were characterised by inflammation and infection. And the distinction between the two was not always clear. And the techniques for treating inflammation of this era that I came into were to stimulate inflammation in the body generally as a method of stimulating immunity. So the traditional techniques were intramuscular course of boiled milk injections. Very painful, very stimulating. If this failed, a course of gold injections. So that was the... Injuries were very, very common, perforating injuries. There was no conception of prevention of injuries in industry and in pastoral industry. Perforating injuries were usually severe injuries. There was a visceral fear of sympathetic ophthalmitis. So if a repaired perforating injury wasn't fairly free of inflammation by about 10 days, the eye was removed. That was regarded as good and sound practice. If we get on to the question of cataract surgery of the time, what would be the frequently asked question by a patient to his surgeon? That would have been, is the cataract ready yet, doctor? Now what did this mean? What it meant was that the cataract was removed and the eye was left with no lens in it. There were no lens implants. That was the aphakic eye. The aphakic eye, without optical correction, had acuity of less than 1/60. So that it had to wear a +10 spectacle lens. The image in that eye was about 30% bigger than the other eye. The two images could not be fused. So when the question was asked of the surgeon, is the cataract ready yet? What it really was about, what's the vision of the cataract in the fellow eye, the second eye? And if that was 612 or 618, it was generally found that a patient would decline to wear a +10 lens because of the confusion of the two images. And generally speaking, the opinion was it was best to delay surgery until the better eye was about 636. Even better if it went down to 660, because then the patient was likely to be happy with a +10 lens. Of course, that meant there was a lot of delay in patients being suitable for surgery. And you did have what you'd call hard-line surgeons and sort of soft-line surgeons. The hard-line surgeons would say, well, you've got a bad cataract, the other eye's not too bad, we'll do the operation, here's the glasses. Now, what often happened was the patient would wear the thick +10 glasses to visit the doctor, maybe use them outdoors, but certainly take them off when he went home, because he could walk around at home in familiar surroundings with 636 quite happily, with no distortion, no disequilibrium, no feeling of being sick in the stomach and motion sickness, which the thick glasses otherwise induced. There were also hardline patients who were determined to get on top of aphakic correction. The choices were +10 lenses, initially glass, very heavy, later optical plastic, but rather later, or hard acrylic microcorneal contact lens, 6mm diameter, very hard. Fortunately, the incision for the cataract had some decrease in the sensitivity of the cornea, and I had, every now, you remember the outlying patients, those that were extraordinary rather than the average. I remember one outlying patient, an elderly lady, very determined, who'd had successful cataract surgery in both eyes elsewhere. She was bilaterally aphakic, and she wore bilateral microcorneal hard acrylic contact lenses, which she never took out. They were worn continuously. They'd worn a sort of a trough in the central cornea. The cornea was diffusely vascularized, but she saw quite well, which was very stable. Fortunately, she had very clean personal habits. Some of my surgical colleagues doing glaucoma surgery, which in that time consisted of fistula operations, deliberately draining a fistula from inside the eye, often with inclusion of the iris. And some surgeons who did glaucoma surgery would say, I won't do a glaucoma operation on a patient who's clearly not got clean personal habits, as they're much more likely to get suppurative endophthalmitis at some time in the future. The standard operation in the 50s was the extracapsular operation, and for the most skilled, it was the Graffi knife. Now, the Graffi knife was about 4mm across. It was a stiletto shape, as sharp as a barber's razor. And the eye was fixated with cocaine drops. The stiletto blade was inserted at 3 o'clock, came out at 9 o'clock, and a series of 3 sweeping cuts. The peripheral cornea was divided, and the last sweep gave a long conjunctival flap, which then could be stroked back at the end and require no suturing. The anterior capsule of the lens was disrupted with toothed forceps. Took a strong grip and tore it out, and then the big nucleus was expressed by pressure on the lower cornea. If there was a lot of opaque cortical matter, that was a very favourable case because you could irrigate that out and get rid of it. If unfortunately there was quite a lot of clear cortical material, that would not be visible to the surgeon, as we had no microscope, no coaxial illumination, no red reflex, and the residual cortical material would be revealed the next day or two as a flocculent mass of egg white inside the eye, which sometimes, if it was a vast in amount, could be washed out a week later, but usually took weeks or months to absorb, sometimes as much as 5 or 6 months. That clearly was a pretty slow and difficult process. And gradually, the idea of intracapsular extraction, the lens being taken out completely intact within its capsule, was looked at. Initially, people used smooth forceps to grip the capsule at the top and jiggle the whole lens in a rotatory fashion till it could be pushed out intracapsularly. The skill involved was quite great, best done by people who were doing it a lot. The main complication was the issue of vitreous into the wound and outside the eye, which was handled with cotton buds and repeated snipping until the vitreous finally gave in and shrunk back within the eye, hopefully. The next advance was the application of a cryoprobe, a frozen tip, which had to be kept away from the iris, spooned out of the way, or preferably a large sector iridectomy performed at the top of the eye, and cryoprobe put on, and the freezing technique adhered to the lens and it was manipulated out of the eye that way. Additional to this is going on through the 1960s now, was alpha chymotrypsin, which is an enzyme which was put into the eye and wait 3 minutes for the zonules to be partly digested by this specific enzyme. I think the Barraquers invented this in Spain in the 1960s and 70s. And then the cryoprobe was applied to the lens and it was sucked out or expressed. I myself visited the great Castroviejo in New York in the early 60s and saw him doing a tumbling technique, which I adopted and used for many years afterwards. This consisted of using cross-action smooth forceps, which were inserted deep behind the iris at 6 o'clock at the bottom. If the sclera was then distracted from that point, the zonule ruptured at 6 o'clock and the lens could be tumbled out of the eye, which held the vitreous back. And this it was satisfactory for me for very many years. Where do we go from there after cataract surgery? One of the great surgeons of the 20th century was Ramon Castroviejo. I can't even say his name properly, no Australian can. But I worked in the north of England, postgraduate stuff, the Leeds General Infirmary in Yorkshire. And the senior surgeon there tended to go and visit prominent surgeons. And then he'd say, "We'd love to have you come and see us." And he'd say to me, Crawford, he said, "Lots of surgeons look good at home, but when you bring them away from home, that's the real test." So he invited Ramon Castroviejo to the Leeds General Infirmary. And Cassie arrived in the early 60s there. And our steriliser was the latest thing you could have in those days. It was a big, vast boiler with bicarbonate in it to prevent the instruments from rusting, because many of them were not stainless steel. And this boiler went all the time, and it was pretty steamy and hot. But that was the latest in sterilisation of our instruments then. And Cassie arrived, we'll call him Castroviejo. Cassie arrived with his toolbox and put it down, and we said, "Let's sterilise the instruments for next morning's surgery." He said, "Oh, just leave it. So he kept going, leave it. And the following morning, they still weren't boiled. And he said, "Oh, just put a tray of spirit there and we'll soak them in spirit." So that's how he sterilised the instruments. Later, when I was working in India, about 1963, we were using a little thing called an arizofake, a little bulb with a suction cup on the end. If you squeezed the bulb, when you let go, you got suction. You put that on the cataract to suck it out of the eye. And it was a tricky thing to actually sterilise that bulb on the outside and the inside. We had trays of chlorhexidine, which was very soapy, and we'd lay our instruments in that, give them a single rinse with saline, and go into the eye with them. But that seemed to be acceptable at the time. The other Castroviejo story is in the middle 60s, I went to New York and I saw Castroviejo do one of his square grafts. He had this special caliper with the parallel blades, and the tips of the square went right to the corneal margin. He was very dexterous, and it took him no time to cut this out, complete it with scissors and a few 6/0 silk sutures. He was very dexterous, it was very impressive. Had 2 tables in the operating theatre, of course, and patients kept moving through. One of the things I'd like to finish on, I think, is what I'd call extraordinary patient stories. You know, because we didn't have a codified assessment of disability, nor any means of rehabilitating people in those 50s and 60s. There were those, of course, that never recovered from their injuries or their disabilities, but there were spectacular successes who took things in their stride. I remember a young man of less than 30 who was brought in, he was led into the clinic, the public clinic. He had bilateral milky blue cataracts, which had come on over 3 days because it was acute diabetic cataract. And so there was a tiny nucleus inside each one of these, so he had a small incision, washed it out. He's given +10 glasses. He was back driving his semi-trailer within 2 weeks with no complaints whatsoever. It showed that it was possible if you were young and you were bilaterally aphakic that thick +10 glasses were quite successful. Another case I remember, a patient had bilateral homonymous hemianopia, loss of field on one side of both eyes. And I certified the patient should no longer be driving a motor car. The patient was dissatisfied with my advice and went back to his neurologist, who had a sight testing chart, checked the patient could read 6/6 in each eye with a macular splitting hemianopia, and certified he was able to drive. Then a young man had a car accident in which he suffered anteroposterior trauma to the vertex, had a traumatic optic chiasmal lesion with bitemporal hemianopia, but central vision splitting and spared. He worked for the road board, so up near Mansfield Way, so I certified that he really was not longer suitable for driving on the roads. Now, the road board, confronted by this problem and being sympathetic to him, appointed him as the driver of the snowplow at the Mount Buller ski resort, which this is the 60s. There were heavy snowfalls. The snowplow was in operation at night on the road when I used to go up at weekends. So I was very careful on the Mount Buller road after that.